Is this live? How about that? Emily, go. Cats, go. Good morning, Dr. Rosensweet.
Good morning, Carolyn.
Sounds like my boss. He's like, how you doing? I'm like, I'm fine. How you doing? Okie dokie. I have some questions for you. How about that?
All right.
All right. We are going to start with number one. And this is interesting to me. This one surprised me a bit. And it came in this morning, actually. So I threw it in there. And good morning, Ellie. I don't have my glasses on. I hope I just said your name right. Good morning. Number one, does testosterone alone alleviate the dryness caused by vaginal atrophy? There are some women who have been taken off of their estrogen and put onto testosterone only, being told that the testosterone was what was at play, not the estrogen.
Well, isn't that fancy?
I know, huh?
I disagree.
I had a feeling you might.
I tend to think in terms of vaginal health as far as it relates to hormones being majorly dependent upon estrogen. As a matter of fact, I grew up in a world where if a woman had significant vaginal atrophy, although we had the woman applying bias to her skin to raise her general body levels, very often we'd give her an extra bottle of estriol, which is a type of estrogen, because that was the one that was healthiest for the vagina. And she'd do about a month or two of also applying the estriol intravaginally. And between the systemic biased and the vaginal estriol, it always worked. It always worked. Now, I know that there's other ways to do this. Like, for example, I've used at one time a combination of vaginal estriol plus vaginal testosterone. And it was a case in severe vaginal atrophy, something called lichen planus. And so I used that combination, and, that was helpful. And testosterone is a crucial, critical, fabulous hormone for women and men. And yet I certainly don't think of it as my go-to hormone for the vagina. It is used intravaginally, but usually in combination with estradiol or estriol. Estriol is my favorite. And occasionally we'll even add DHEA to the intravaginal mix. But think in terms of estriol vaginally. Think in terms of estrogen for the health of the vagina. And if there is significant vaginal atrophy, it can take a while. It can take between 3 to 6 to 9 months if you're using topical only, which is why frequently we'll add a little extra bottle of our organic oils-based estriol for a woman to do. She won't need more than one of these bottles. And the estriol doesn't add very much to the potency of the estrogen she's taken, but it sure does help that vagina. And a woman should count on getting great vaginal health restoration to our intercourse. It's not necessarily going to return to the 20-year-old, 30-year-old vaginal status, but one of the marks and measures of really important treatment in menopause is to heal that vaginal atrophy. And it is quite remarkable that how does a woman know where she has enough estrogen, for example? Well, the medical literature has done some beautiful studies that tell us what's enough and what's not enough.
Right.
And if a woman is not getting her restoration of her vaginal health, she does not have enough. And it's one of the ways that we correlate and define the lower limit of what's appropriate amount of estrogen. If a woman gets restoration of vaginal health, we want a number of the estrogens that actually will produce restoration of vaginal health. And we don't want to fall shy of that. And it turns out the amount that a woman needs to restore her vaginal health also is the right amount for bone health.
Yeah.
The two of them correlate really well. So in our questionnaire in the beginning, we ask a woman, are you using lubricant on intercourse? If you're having intercourse, do you have pain on intercourse? And we don't, that process of healing does not stop until a woman says a major return of vaginal health.
And a woman will know. Believe me, a woman will
Testosterone,
know.
wonderful hormone. It's not the go-to hormone. And there's someone said that they stopped the estrogen. Well, that's a whole other subject. So I'm going to just stop talking and go to
Leave
the.
it at that.
I'm not very.
Vaginal atrophy, it's not something, like it's not like dinner conversation. Heck, guess what? But boy, it matters. And we've discussed this, that when you're walking around and you're very aware that you have a vagina or a urethra, or it's so uncomfortable. And so it was a little surprising to me to hear that estrogen would be taken away and testosterone put in the place of. So thank you for.
I don't understand that. I don't agree with that.
Yeah.
That to me, something I would challenge that approach to menopause big time.
Yeah.
And you know what? Every woman in menopause, we're replenishing proper levels, optimal levels of estradiol, estriol, testosterone, progesterone, DHEA, and a lot of times thyroid. All of them. There's optimal levels for all of them, and we want.
Yes.
And just to go a little further with that vaginal atrophy, and this is what you and I were talking about before we went on the air here, that when you look at the short range, the first 5-10 years of a woman going into menopause, hormone replenishment can make a wonderful difference and get them back online, sleeping, energy, skin, lots of things, vaginal atrophy. But in the long haul, I want to give women a sneak preview if they don't already have it.
Oh my.
Life is going to matter amazingly to you when you're in your 70s and when you're in your 80s. And for those of you who are in your 90s, it's going to matter as much to you then as it does right now, as it has your whole life.
Amen.
What happens in this country is there is an enormous, millions and millions of women are not at home anymore in their 80s and 90s. They are in assisted living facilities or nursing homes, and they're there for primarily insufficient hormone replenishing. Oh my God, what? I was talking to a female Dr. Bergson, a doctor who's really expert in menopause, and we were just imagining what the planet Earth would be like if women were treated in the nursing homes that are all over the place, massive amounts of them. I spent years in Florida. Oh my God, the number of nursing homes in the town I lived in and assisted living facilities, there was major choices because they're thriving. And one of the reasons they're getting there is women have vaginal atrophy. That's one of the reasons they're there. And because they get into adult diapers and they get unmanageable at home. Now, the other part of that, and this is where testosterone comes in, is women get into those adult diapers because the muscle that holds up the bladder and the pelvic organs, it undergoes sarcopenia, loss of muscle mass. The strength isn't there, and that's how one of the ways that women get incontinent. It's the recipe for incontinence. Sarcopenia of the levator ani, that's the muscle, and vaginal atrophy. Women are in nursing homes because of that and because of the sarcopenia, the loss of muscle that makes them transition from canes to walkers. Okay, you can stay at home with walker, but when you make that transition from walker to wheelchair because you've lost your muscle strength in your lower extremities, that's assisted living too. And I promise you, there's many, many strong women in assisted living facilities and strong of heart, strong of soul. But really, many of them, it was a major, major loss to have to move out of their home and out of their family. And so, as you and I were talking about, one of the most important reasons for getting on hormone replenishment, is staying active and alive and being able to play with your great grandchildren. And you're walking around, you're going shopping, you're thinking clearly. You're not wearing adult diapers, and you're not even using a cane. And in order to do that, for the vast majority of you, you are going to need estrogens in the form of bias is the best. Testosterone. So the question originated with testosterone. It's not like I'm trying to diminish the importance of testosterone. My God, that's where the sarcopenia comes from if you don't have enough testosterone. And there isn't a single one of you out there, 3 years with no period, that doesn't have low testosterone and low DHEA, way lower than you want it to be, and it's going to help you in the long run. So it wasn't trying to diminish testosterone. And also progesterone and DHEA and thyroid too. These are our power chemicals. We want these things. And the best thing you can do for yourself in replenishing your hormones now is all the benefits of now, but it's the long-term stuff. It's how you're going to feel when you're in your 70s and you're in your 80s. I tell you, it's going to matter to you. So do it for that reason.
So, I mean, there is such a thing, which was my thing, as a rapid relief. I wasn't thinking, 20 years down the line about that. But boy, you brought that up and it caught my attention, and it caught the attention of many. And I think that it's so important. It is so important that we understand how crucial. It would be like my saying to somebody, would you mind my taking away your insulin for a month or two? I mean, no, I think I'd like to keep my insulin. Thank you very much. I mean, it's almost that, not even almost, it is that big. And I run across women who are like, I will never do hormones. No. I mean, and I'm like, okay, live and let live. But I got to tell you, I'm not so sure that's wise. Study it, educate yourself, learn, and you might think a little bit differently. I think it's a subject you and I are going to probably further our conversations on. I want to welcome everybody. I know Rod is here and Lee is here and Sheila's here. Hi, Sheila. Long time. And also Elizabeth is here. Oddly, I can't get down. There are other women here. Maybe you can see them, but welcome everybody. Happy you're here. And we'll get to your questions in a minute. So yeah, thank you for that, Dr. Rosensweet. It's a big subject. It could take up a whole, like we were talking about, 3 months of an interview for sure. That one subject, it's a big deal. So my second question comes in here. And this is about you. It is, I know that I saw somewhere on this site group that our doctors can call Dr. Rosensweet to learn how to dose us with his menopause method oils. Is this true or not true?
Well, it used to be that we could offer that. And we've changed our mission. We realized that women were going to physicians who had broad-based practices, and that menopause and hormones was a small part of it, and that the doctors were not getting excellent at it. These are the strongest biochemicals in our body. We've changed our way of operating, that we're training those who want to specialize in it. And we're suggesting to the women who are interested that we hook them up with someone that's in our program, because they're specializing in it and they run every single case by me, single person by me. That's my favorite way. But, there's always exceptions. And my goodness, if you had a doctor that was interested, yes, please send us an email. I would definitely be willing to talk to them, because someone who has the interest, and what I suggest is you read my book, because you'll be able to co-create. I laid down the roadmap for women. I said, this is what you're looking for. And so between a doctor who's really interested in the 24-hour urine hormone test and my book, that's another way to do it. I mean, so let's figure out how to do the whole thing together, because The bottom line is we want you to have expert treatment. And we get it right in the first 4 months and continue it for every day that you're on Earth. And you're the one who's going to just go fantastic. So yes, I would be open. So to talking directly to your doctor. And be sure and download the book, because sometimes the doctors aren't going to take this on as their specialty, but there's enough there between talking to me and you reading the book and you knowing because what it's going to come down to is you're going to be applying these hormones to your skin and taking some orally maybe, and you're going to feel it in your body. And a good percentage of what's going on is the alleviation of your symptoms of insufficiency. And you're the one guiding that. We teach you how to do it. The roadmap is right there in the book. So if your doctor's willing to prescribe, it's fun for me to think out loud here, because I was trying to think, ultimately for women to have fabulous access, wouldn't it be amazing to, oh my God, think of this over the counter? And it's never going to happen. This stuff is too strong. But what's a good substitute for it? Well, I wrote the book. So women will be able to figure it out, and especially if they've got a warm, friendly healthcare provider, you can do it.
You can do it. You can do it.
You can. Your provider can contact me at DRR. That's Dr. R. DRR at menopausemethod.com, and I'll do a Zoom call with them.
That's really cool. That's really cool. And I think that it would be well appreciated. The book is Happy, Healthy Hormones, and it is up on the group, and it's downloadable. I have it, and mine's in a binder, and it's underlined and highlighted everywhere, and I love the book. The book is excellent. And it's fun, too. It's not like dry reading. Anyway, good morning, Alexa and Karen and Tia. We'll get to your questions in a second. We're happy you're here. And thank you for that, Dr. R. So I'm going on to my third question, which has to do with the 24-hour urine test. And this woman says, I really want to ask my doctor about doing a 24-hour urine. She is always, or it says she always does a day 21 serum blood test. Can you explain again why the 24-hour urine is your absolute favorite way to go?
Well, a day 21 blood test is valuable, sort of, for a young woman who's not being treated with hormones.
Okay.
And yet these are not the women who show up to doctors' offices. Day 21 is the ideal time to test in a woman's cycle who is cycling regularly. But women who are cycling regularly, their primary interest is not necessarily, I think I'll get a blood test. Who's showing up with menstrual issues? Well, one of the most common ones is they're not menstruating regularly. And day 21 is a tough one to predict. Really, we're talking about that time in a month when progesterone output is maximal. In a 28-day cycle, it's day 21. And that coincides with an estrogen output that is very robust. It's about 2/3 of what it is at peak, which is mid-cycle. So, yeah, interesting, but let me talk about a woman that you're treating, a woman who's being treated with hormones. My life changed when a colleague of mine that I was talking to, I said, God, these saliva tests don't work. I can't even understand how to do blood testing in a woman who's taking hormones. When do we draw her blood? I mean, she puts the hormones on her skin. They gradually increase in her blood, maybe at 1 hour, 2 hours, 3 hours, 4 hours. As they get absorbed into the bloodstream, they're not very prevalent, and they quickly leave the blood. And when she does her peak level depends on when she took her last dose and how good her absorption is. Mm-hmm. I could not figure out how to do blood. And then I early on learned that even the North American Menopause Society and the American Endocrine Society of Endocrine Society and the American Gynecology and Obstetrics Society, they say don't test women in menopause that you're treating. For one thing, blood tests don't work and saliva doesn't work. And there's an element of what that's true. I know a lot of people do rely on blood tests, but all these when did you take your last dose of hormones are totally covered and bypassed by collecting your urine for 24 hours. And it's not like 24-hour urines is this brand new thing.
Yeah.
In 1970, a University of Nebraska oncologist did a study of the 24-hour urines of women who had breast cancer and healthy women, compared the two. Why did he choose 24-hour? Because you get to look at so many things. You get to look at the hormones. You get to look at what the hormones become in the process of being utilized, the metabolites. You get to look at the androgen and its metabolites. You get to look at progesterone, corticosteroids. It's just a phenomenal test. And well, my colleague said, yeah, you got to do the 24-hour urine hormone test. This is about 20 years ago.
Yeah.
You're going to love it. It's going to tell you everything that you want that's going on in a woman. So, it's a technical explanation, but the bottom line is nothing works well in testing a woman who's being treated with hormones, except something that works fabulous, and it's the 24-hour urine hormone test. The blood test can give you a rough idea. You don't know when to draw the blood, really. You can make a guess. It's going to give you a rough idea. It's not going to tell you the metabolites. It's not going to tell you what estrogen becomes in the process of being utilized. That's the metabolites. You never get to learn about hormones unless you see the parent hormone plus the metabolites. That's technical, but that's true. And I am not talking about these collect your urine 4 or 5 times in a 24-hour period and pee on a filter paper. No, that's an NO. There's too many technical scientific issues with that. Now, right. I know it's marketed very profoundly, and the people, they're just really attracted to it. I don't know why. It's more expensive and it's so less accurate. We know inside stories that they're having a lot of extraction problems. So I'm not here to injure someone's business, but I am here to ask for excellence, for giving women these powerful biochemicals called hormones. Let's get it right. This is not a game we're playing out here. Pardon me.
Right.
For being intense about it, but I have a lot of feelings about the damage that has been done to the treatment cause because proper testing has not been embraced. It's really disturbing to me. And it feels like the Wild West to a lot of physicians and nurse practitioners who want to venture into the territory because there's confusion about all these things. So, you can tell I'm an opinionated guy, and I really love my opinion.
Well, you worked hard for it.
And hormone testing is fabulous. And 24-hour urine hormone is going to give every practitioner the dream view of what's actually going on. And one of the reasons that they don't embrace it is it's a learning curve. When I first saw the number of analytes that were reported in the first 24-hour urine hormone test, I went, oh my God, this is a whole new thing I've got to learn. And it took me about 50 tests before I started getting my arms around it. But fortunately, there's a lot of people at labs there to guide you and figure it out with you. So,
which gets back into that, I guess like 15-minute, time slot that you have, and you have a very busy practice, and God bless.
There's challenges, and this is why it's not embraced, and this is why we're all about people specializing in treating women with hormones.
Absolutely.
And not only that, ultimately, when a woman's on hormones, we want to know is she on too little or too much? And so what the North American Menopause Society has said, you do not have to test. Symptom alleviation will tell you what you need to know. Okay, I love symptom alleviation. I got into the whole treatment of women by starting on low doses and gradually alleviating the hot flashes by gradually increasing the dosages. It's a beautiful technique. So 1 year before I went to the annual teaching event I did, I used to like to evaluate, have I learned anything new in this last year? And I thought, I'm going to take a look at my year's worth of 24-hour urine hormone tests. And I selected 51 of the tests I had done. These were of women who said, wow, I was feeling horrible and now I'm feeling good. And that's when we test women. And here's what I learned, that 75% of these women were not in the range that was optimal. 75%. 50% of them, even though they felt good, they did not have enough estrogen in their body to protect their vagina and their bones.
Right.
Not to mention their arteries and their brain.
Mm.
Vagina and bones are sort of minimal. You need more to protect your arteries and your brain, among other things. 50% said they felt good, but they weren't on doses high enough to produce the right amount in their urine. 25% were feeling good, not having symptoms of overdose, but were on dosages more robust than I consider safe because they're on doses that could promote breast glandular cell proliferation. A young woman needs breast glandular cell proliferation every month, and she does. She gets mitosis and new cells added in the anticipation that she could get pregnant and all preparing for lactation during every menstrual cycle.
Right.
She needs mitosis and she needs breast glandular cell proliferation. And it's one of the reasons in a young menstruating woman that sometimes during the cycle you feel a little fuller, because there's more cells there. It's not the only reason, but that's why. And then if you don't get pregnant, those cells disappear. We don't want mitosis in a 50-year-old who doesn't have the same immune system power that a 20-year-old does. And you don't need it. You can protect in almost every instance your vagina, your bones, your arteries, your skin, your libido, your energy, your hair. So many things, not with youthful levels of hormones. You can come in right below that. It's the optimal zone for women. 24-hour urine test was correlatable with the medical literature that told me it was too little and too much. In fact, the lab we use is actually printing out what I extrapolated from the medical literature, showing you the optimal zone, not too much and not too little. So, I love the 24-hour urine hormone test. I would not be here today talking to you without it. That's where I learned most of my stuff, from the women and comparing the women to the testing and getting them right, dab right in the sweet spot of the great zone for each of the hormones. And you want to be there. You don't want to be dabbling along with too little. That's not going to help you in your 70s, 80s, and 90s.
Right.
You're really going to start to feel it as you degenerate. You could even feel that, I got rid of my hot flashes. I'm through menopause. There is no such thing as being through menopause.
But I hear that often, I'm so glad that's over.
Yeah, it's not. Their hormone levels are peaked when you were 20, as I've illustrated many times. They gradually decline. Oh, yeah, I hear not enough estrogen, so you don't menstruate, but they don't stop declining. And those later years declines, as I was mentioning earlier, they are so significant to you. They will matter to you so much. I know I'm repeating myself, but your life is going to matter as much to you when you're in your 70s, 80s, and 90s as it does now.
Right in this moment. And it's so sad. I see it a lot. I see it in women who are in their 50s. Yeah, I don't know. The symptom alleviation thing is, like you said, it's one thing. And so, okay, you're not having hot flashes, you're feeling a little bit better, and you go on, and that's great. And then you say, well, I'm done with that. Thank you, God. It's a whole lot more to it, as in bones, brain, artery, cognition, which Dr. Avram Blooming talks about too in his book, Estrogen Matters, and how that's what got, the ball rolling there in regards to estrogen and cognition. It's a whole lot. So menopause is a specialty. I'm going to go with you for sure. I do the 24-hour urine test once or twice a year. Very happy with it. And thank you for that answer. A lot of questions on the right here. So I'm going to go to my last question that I have written down. And this one is, do you think that it is beneficial and or helpful to start with one hormone at a time, like getting your estrogen up to really good levels before adding in progesterone. That was actually the
That
question.
is a valid approach. And it was one that I started out with because my theory was that if a woman could start a hormone and feel what that hormone felt like inside of her body and felt the direct action of that hormone, that'd be an optimal way to go. So then she would get a sense for, well, how much estrogen do I need?
Right.
And then I very quickly switched, that's not physiologic. That's not how the body works. And it wasn't as elegant as I thought it was. So how the menopause method addresses hormones is we always start with the combination of biased plus progesterone. They're just too important, and progesterone and estrogens balance one another. So the method that, this is how we do it. We do those two right out of the gate. Now, there's even another exception. There's a certain number of women who go into the perimenopause and early menopause, and they've got decent testosterone or even elevated testosterone, and they have decent DHEA. I find this to be less and less common. It really blows my mind. But they can have adequate testosterone. And so we don't necessarily think of starting a woman out also with testosterone or DHEA. But there's some women that we intercept in early menopause or 5 years in that it's so obvious that they're testosterone deficient. They've got bicep flab. They can't get out of a chair without using their arms. They got zero libido, and they used to have libido. They're not thinking clearly and decisively. So we do this. We prescribe a given dose. Here's an example of a dose that we suggest of biased and progesterone.
Right. I know that card well.
We start low and we gradually increase. But we'll also start these kind of women who have obvious androgen deficiency on a steady dose of testosterone and DHEA, low, because we want to start replenishing that too. We don't also have them increase that. But then there's going to come a time in a month or two where the women have oscillated into an optimal biased and progesterone dose. Meanwhile, these other women, they've been also getting a low dose or a decent dose of testosterone, but it's steady. And then once we oscillate in with the bias and progesterone, then we'll start increasing the testosterone. So yeah, when I first started out, I thought, let's just start with biased. And nowadays, if I got a woman 3 years into menopause who's lost her libido and she's got cough incontinence and she's lost her muscles, losing her muscles, I'll also start on a steady low dose of testosterone. Once we figure out the bias and estrogen, we'll gradually increase the testosterone. And we then, when a woman says, I think I got it, we do the 24-hour urine hormone test to confirm they are in optimal zones. And that's how we do the first 4 months, is usually what it takes in most women.
It's fascinating, and it is 4 months, because I know for myself, and using, and your method is the only way I have used. I'm going into year 3 now. I feel a lot better than I did, that's for sure. As I think you might see, considering when I first met you, what a mess I was. It brings up a question for me that I actually didn't write down, but there is a woman who has a mother who is in her 80s who's very frightened of hormones, and I understand that. And so the woman was thinking of possibly having her mom go on one of the over-the-counter creams at first, prior to starting with something a little bit stronger. And do you have any feeling either way about that?
Well, legally, the only female hormone that exists over the counter is progesterone. You can also get DHEA over the counter. And if you're going to do that for women, I'd say don't get anything higher than 15 milligrams of a DHEA. 15. So those two you can get over the counter. Legally, you cannot get biased, but you can. And I don't know what it is. And I have a pharmacist friend that approached these people who were offering over-the-counter bias, which is totally illegal.
I didn't know that.
Oh, yes. Yeah, these are prescription items, and they ought to be because they're so strong.
Yeah.
And so we don't know what's in there. The pharmacist friend of mine started questioning these people, and because it says biased, it says the estradiol and estriol in there. And he said, well, do you know that that's totally illegal? You cannot do that in the United States. And the guy said, well, it's really an extract, and I don't know.
Ooh.
Yeah, so we don't know what that is. But this is something, here's what I would recommend. We developed a formula for the elderly. We call it Elder. In fact, we've got 2 different strengths. And because we know that for the elderly women, sometimes it's harder to comply by having 3 different bottles, for example, we put everything in one bottle. Ordinarily, we do not combine the hormones, especially for the younger woman. We want something far more precise for very specific reasons. But with the elderly, we put biased in there. That means estradiol and estriol, progesterone, testosterone, DHEA, and pregnenolone for the brain. And it works.
Mm-hmm.
It's once a day, a woman applies drops out of a bottle like this. She does have to shake it. And so that's what I recommend for the elderly. And you can even keep on increasing it until a woman gets breast tenderness, because that can happen. And then you back down.
Right, because that
And, yes, you're really brought up this whole other subject here, questioner.
Sorry.
The subject is people being terrified of estrogen. I mean, the American female population, the population of the female world, was poisoned with wrong information. That study that everyone's frightened them about hormone, from the year about 1,000 years ago up until 2002, women were taking hormones. By 2002, there was 18 million American women in menopause on hormones. 40% of American women in menopause. Nobody blinked an eye. There was a book written, Feminine Forever. It really popularized them because this doctor said that women need hormones. And as someone pointed out in something I was listening to last night, which I've heard many, many times, but it was funny how they put it. Yes, it was this doctor at a conference was saying, back in the prairie, life on the prairie days. What's that book on the prairie? I'm sorry, it's Little House on the Prairie. He said, this is how he put it. He said, yeah, and the Little House on the Prairie days, there was no menopause. Women didn't live beyond that. Now we're living 1, 2, 3 decades beyond the Little House on the Prairie days. That's how he put it. I thought that was so funny. Man, you need these hormones. So we have, like in our book, we discuss risk. There's a risk discussion in the book that you were referring to. Your family friend, Dr. Avram Blooming, has written this book called Estrogen Matters that Carolyn actually introduced me to Dr. Blooming. What an honor. This is the art on risk. And you as a daughter might read that book because you're the one who's going to talk to your mom, because that fear needs to be dispelled first. Like, that's part of the menopause method, is we spend time during that first visit dispelling that myth. In fact, we have a book out there, and our staff could probably link you up with it. It's a mini book called 8 Myths of Menopause that I actually did. It's a video series. And here's the thing. If you know in your bones that myth was wrong, and you tell your mom, we have to help your brain. You were told a lie. The same people who did that study in 2017 published in the same journal that they originally published their wrong study, that after 18 years of follow-up, women who are treated with hormones do not have increased risk of breast cancer, heart attack, and stroke. In fact, they're at less risk.
Right, it's to the contrary.
Women who are treated with hormones, even if it's Prempro, I'm not going to go into the details of what that is right now. They're at less risk for developing breast cancer, heart attack, and stroke than women who go untreated. That's what our moms need to know. It's a tough one to antidote, but they will listen if they trust you, and they
Yeah,
will listen if you have authority, and they will listen if a doctor knows in their bones that that's true. Well, there's not many doctors who know that at this point.
well, they were taught otherwise, because they were taught in the day when that study was out, and they bought it hook, line, and sinker, and they didn't really want to do any harm, of course.
So your mom is not correct, and how do you get to communicate to her in a way that she gets to receive it and get it? That's a whole other subject. It's something in the physicians and nurse practitioners and compounding prescribing pharmacists that we mentor. We spend time on that subject. How do you communicate to a woman that actually, we're all at risk for cancer, we're all at risk for all kinds of things. As a man, I'm at increased risk for prostate cancer. Women are at increased risk for breast cancer, and there's reasons why. However, women who are treated with hormones are at less risk for breast cancer, heart attack, and stroke than women who go untreated. Well, we have techniques of helping women see that, and that's the elephant you're dealing with.
Yeah.
How do you help your mom bridge between that? And then if she does, I'd get her the proper treatment, not over the counter. It's not hit and miss. It's not okay. You want to get this one right. And you either go to someone who's specializing in this and they know how to get your mom in her green zone. It's not trying to restore her period. No way. We're not trying to make her 20 again, but boy, can there be benefit. And the final thing I'd like to say is my mother-in-law at one point, she couldn't get out of a chair.
Mm-hmm.
And she was in her kitchen, and she was so weak in her lower extremities that she made a turn and fell and fractured her hip, her pelvis, and her shoulder, and was in rehab. She had surgery, and she was in rehab for 3 months. And when she got out, she was worse, because when you have that big of a body blow, you get more atrophy of the muscles. And we started treating her with MM Elder. She was the original one. And we have a video of her somewhere in our system. She's sitting on a low couch. She's got her arms up in the air. Hi, Mary, wherever you are.
No.
It's happened many years ago. She's now passed away. She's got this big smile on her face. She's got her arms up in the air. She's sitting on a low couch, and she stands up from a sitting position. Try doing it yourself here right now, for those of you in your 70s and 80s. So I say, whenever a woman is inspired to do it, 80s, Mary was 86, I think, when we started treating her. My own mom, I started treating in her late 80s to her benefit. She started using a cane. We put her on MM Elder. There came a time when she no longer used a cane for a while.
It's amazing. It's amazing. I know that from your webinar, yeah, the picture of your parents and the picture of your mother, it's really poignant, definitely. And many women do ask, am I too old to go on hormones? And
you need to have special care. There is an exception around cardiovascular. There's some women that we had a cardiologist see, and that's a whole subject, but it is never too late. Think of it, 86 for my mother-in-law, 88 for my mom.
Yep.
Now, here's another thing. The earlier, the better. Oh, God. We like to start treating women in the perimenopause if we can.
Well, that's
the best time.
Yeah.
But whenever, that's the good time. That's the great time. Whenever. Want to. Yeah.
Whenever is the great time.
That's the best time. Whenever.
Just do it. And, having somebody that specializes in and having that trust in that relationship is so important. It really is. So I have Iwa here. I have Kelly. I have Krishna. Hi, Krishna and Kelly. And it ain't fun, Elizabeth says. So, Dr. Rosensweet, I apologize. For some reason, I can't get down to the bottom questions for some reason
Well, what you
today.
do is you take your cursor and you move it over to the bar that's to the right of this chat, and then you slide that bar up to the top, and that'll give you the first questions. And I can tell you what the first questions are.
Thank you, because it's just not working for me. And I know that
Okay.
we have quite a few, and I
So
apologize.
here's from a woman who has an unusual name. She must have been named after in a modern time. Her name is Facebook User. Novel. Good morning, doctor. Why does a postmenopause woman, when put on progesterone, is recommended to take 25 days and then 1 week off? Just go 2 days of, and then insomnia so disturbing. 2 days off. I like this. When we originally start treating women in menopause, we start with low doses and we gradually increase, and we do not stop. It's continuous. And we're really there to raise their general body levels. Now, here's a concept for you. What if the woman, through her own gradual increase in symptom alleviation, plus our testing, showed her to alleviate all her symptoms, and she was in a very comfortable zone? But what if it turned out she was taking 6 more molecules of hormones and just couldn't detect that there were 6 extra molecules every month?
Yikes.
Well, because these hormones are fat soluble, might take quite a while, but she would be accumulating excessive amounts of hormones from her daily treatment. It's 6 molecules a day. I'm just being facetious, but it does give you an idea of what the concept. Well, in order to avert the gradual overaccumulation, we do a technique. Once a woman is on great doses and she tests great, we say, now we want you to stop once a month. And then we ask, and they'll say, well, how long? We'll say, here's what you do. You stop and you evaluate. And let's say on the first day of stoppage, you feel fine. And on the second day of stoppage, you feel fine. And the third day of stoppage, you get a hot flash and you can't sleep, much like the questioner is saying. We know that by 3 days, your general body hormone levels depleted to the point where you got symptomatic.
Right.
Well, we don't want you to get symptomatic once a month. So what we suggest to women is now, from this day forth, stop for 2 days a month. What that'll do is, if you're accumulating 5 more molecules a month, that once a month stoppage will prevent that accumulation. But it's never fixed. It's never stopped for a week. That's way too long for most women. So Miss Facebook User, just kidding. That's too long for you, and it's too long for almost every single woman that I've ever treated. A week. It's usually 1 or 2 days of being off is plenty. And we don't want a woman to get symptomatic. So if she got symptomatic in 3 days, like she started getting insomnia in 3 days, we'd say, okay, from now on, stop for 2 days. And if she said, no, I'm not getting insomnia, but I'm still having a little trouble sleeping, I say, stop for 1 day. We don't want you to get symptomatic. We just want you to stop once a month to lower your hormone levels just a little bit so that you don't accumulate. So that's the proper way to do it. I just described it. And then I'm reading at the top, and you tell me when I catch up to where you can see it. So there's just some nice comments. But here's Lee asking, I'm wondering if it's best to dose estrogen cream, E-cream, 2 times daily, or if once is sufficient. Another great question. The optimal way is to mimic nature. Copy nature, as one of my dear colleagues, Dr. Jonathan Wright, a real pioneer in hormones, suggested. He said, when in doubt, copy nature. Well, your ovaries didn't put out estradiol once a day.
Right.
Your ovaries put out different levels throughout a day. And copying nature would have you take estrogens more than once a day, maybe 4 times a day. You could probably mimic ovarian action best with 4 times a day. But you got to make a balance between being practical and copying nature. So the balance we've achieved with estrogen and with Biased is twice a day. So you take your Biased in the morning, and that's going to help you do the day, and you take some Biased in the evening, and that's going to help you with your night. Because alleviating and preventing nocturnal hot flashes is a big deal because that can disturb your sleep. So Biased twice a day. You don't have to do that with testosterone. Progesterone, most women, we have them take it only at night because progesterone is so helpful at night. Now, there's some women, this is what happened to me. So many times a story like this happened. I'd see a patient after a couple months of her being on hormones, and I instructed her to take her Biased twice a day. That's somewhat copying nature and really addresses daytime well-being plus nighttime well-being. And take your progesterone at night because it's so helpful for sleep. So I had women come back to me for their follow-up visits and say, that progesterone really helps me at night. And before I go to sleep, it really calms me down. And it's really alleviating this anxiety that I never had before I went into perimenopause. Why can't I take progesterone during the day as well? And I'd say, what did I know? I mean, this is 25 years ago. I'd say, yeah, take it during the day too. Fine. And just don't take too much, because if you take too much progesterone, you're going to get groggy. So you're not going to want to operate heavy machinery as an automobile. Keep yourself clear, but take it during the day. And I can't tell you how many times women said, well, I already have been, and it works really good. I no longer have my daytime anxiety. So even progesterone, there's some women that really benefit, especially those who never had anxiety of significance in their whole life. And now they're having anxiety when they go into the perimenopause. Take it twice daily. Just take your most substantial dose at night and take enough during the day so you learn your right amount so that you're not getting groggy. Because it's such a calmer. Progesterone is the great calmer. Yeah, progesterone is so important for sleep. Progesterone, and too much progesterone is too much calm. So I'm just telling you, testosterone you don't have to really take twice a day. You can take it once a day. And same with DHEA. You'll just do fine. You'll do fine with it once a day. I'd say in the morning, because you want to energize. Testosterone can be energizing. Sometimes we suggest, just for convenience, that a woman take her Biased once in the morning and once at bedtime, along with her progesterone at bedtime. Convenient. But there's some women that evening estrogen is a little too animating. And it gets women too energized. So some women have to take their evening Biased they discover the time. They try 6 o'clock. No, they're still too animated by bedtime. They try 5 o'clock. And that does pretty well. They're still able to go to sleep. They have to find the proper time for each.
There's a learning. It allows you to kind of take your menopause back into your own hands in a really good way, I found. Yes. No.
Yes. In 1 minute, I'm getting a call from the family member, and I did decide to go extra time today, but I have a family member that's just texting in with me. So if you talk amongst yourselves for a few minutes.
So much for the extra half hour, huh?
Well, it may be that, let me just communicate.
Okay. Hi, Lean. Good morning. I'm going to ask that question if I can. Give me a sec here.
I'm back.
All right. Cool. That was an easily fixable problem. Anyway.
We'll if they need me, I'm going to I will cut it at the hour.
Do a hard stop. Got it.
Yeah.
And that's respectable. That's fine. These two questions I'm seeing, one is from Lane, one is from Kelly. And she says, good evening. She's in Europe. So it says that if already on testosterone, what are the benefits of taking DHEA2? And then the question below that says, what about using DHEA instead of testosterone? Can testosterone make you irritable and angry? So they kind of go together in a strange sort of way.
I'm amazed at the how high quality these questions are.
No, they're wonderful. I know.
I'm going to take you back to copy nature to answer this question. Turns out DHEA, milligram for milligram, is the most prevalent pro-hormone or hormone in our body. There's more DHEA than all the rest of them. And because I've looked at hundreds and hundreds and hundreds of 24-hour urine hormone test results, you see that women have a certain amount of DHEA, a certain amount of testosterone, a certain amount of estrogens, and a certain amount of corticosteroids, and a certain amount of thyroid. And women vary individual to individual, but there is a range. And I am a copy nature guy.
Yes.
I don't want to reinvent someone. Why in the world would I only give someone DHEA when they need testosterone, estrogen, progesterone, and thyroid?
Yeah.
Well, here's a theory people have. The theory is, well, DHEA can be converted to estrogen and testosterone.
Interesting.
And that is true, but you have no control over it. Like, if you really wanted to go by that theory, all these steroid hormones are made out of cholesterol.
Mm-hmm.
Why don't just eat a bunch of butter and forget about this prescriptions and doctors and stuff? You'll get plenty of cholesterol.
Yeah.
No, because you have no control over it.
Right.
Or you could give the very first hormonal active in the cholesterol development processing cascade, which would be pregnenolone. Why not just give pregnenolone? Well, there are reasons to give pregnenolone, but you can't control it. You don't know which pathway it's going to go down in any individual. And after decades of doing this, 25 years, I can tell you, you want to get each one of those things accurate. And DHEA, there's studies done on DHEA. It's not as identifiable, the symptoms. Like if you have hot flashes and you take, most women take estrogen, those hot flashes are going to go away. Well, there are no terrifically specific symptoms to DHEA deficiency. But I can tell you, there's I was just listening to a psychiatrist talking about mental function and the importance of the accurate amount of DHEA, and studies have been done. But you don't try and get the whole job done with DHEA, because that's not how the body does it. You have the right amount of DHEA, and by the way, women, no more than 15 milligrams orally. If you do, the highest likelihood is you're going to produce excessive amounts of DHEA. In the world of hormones, too much is not okay. Doesn't matter what hormone you need. These are way too powerful biochemicals. You want to get the testosterone right. And the way I can get the testosterone and the DHEA right is by administering DHEA, administering testosterone, administering bias, and administering progesterone.
So
be specific about it, and then testing to make sure you're in the zone. So if you have unlimited funds, and the only tool you have is DHEA, you could take DHEA and test out your theory and do 24-hour urine hormone tests and see what you wind up with. I wasn't willing to do that experiment. I wasn't willing to give a woman cholesterol and see if she produced the steroid hormones, or pregnenolone for that matter, although I treat with pregnenolone for other reasons, nor DHEA. I want the woman to have the very accurate copy nature amount of those, and what it takes for, I'm not going to do the experiment of doing 5 24-hour urine hormone tests to see if the DHEA is converting properly to the hormones and the metabolites.
Got it. And so this is going to lead me to another question. Where did it go? And I'm missing it kind of. It's from Lily, and she's asking about if one takes spirolactone, can one also use, and then it cuts off, can you see that question? She's asking about spiralactone, and she wants to know if she can also use, I believe, her hormones along with it.
Yes, and you can test it's spironolactone,
Sorry.
and a lot of people use that. Not a lot. It's a decent remedy for a certain type of blood pressure elevation. I'm assuming that that's what that's on. That's the reason for it. And also, there's a whole relationship of a hormone called aldactone.
Yeah.
Racing, and you absolutely can do it. You just do a 24-hour urine hormone test, and in the 24-hour urine hormone test, you also add the aldactone to make sure if you're using spironolactone that you're getting your aldactone correct, along with your corticosteroids, your DHEA, your biased, and your progesterone, your testosterone. Yes, you just be accurate, and the 24-hour urine hormone test is going to tell you is going to give you that information.
Got it. There, and I'm not understanding. I'm going to fix this because I'm not understanding why I'm not able to scroll down for these questions. But there was one question that had something to do with taking natural remedies, and we got into this a little bit in our last interview. Instead of hormones proper, supplements, herbs, this, that, the other. And how do you feel about that?
The question is from Tia, and it's, what about over-the-counter natural homeopathic creams?
Thank
Well,
you.
I love homeopathy.
Mm-hmm.
In doing homeopathy for a couple of decades, is one of the tools I had. I learned that some people responded to homeopathic medicines and some others did. A certain number of people did not necessarily respond well to homeopathic remedies, respond efficiently. But here's the deal. If you have a vitamin D deficiency, you're going to need to take vitamin D and sunshine.
Yes.
If you have a vitamin A deficiency, you're not getting enough vitamin A in your food supply, and you're probably going to have to increase your vegetables and maybe even supplement vitamin A. You don't want to take an herb that, well, this is not a good example, so I'm going to go back to the hormones. If you have a hormone deficiency, you want to take the hormone, because in the world of treatment, there's two types of treatments. One is you replenish the molecule that you're missing, and that's bioidentical hormone treatment is an example of that, or taking vitamin A through the food supply or through a supplement. You're replenishing the vitamin A that you weren't getting enough of. You're replenishing the hormone that you didn't have enough of. Or there's everything else on the planet Earth that you could possibly take, and that's called a medicine. Everything that's not a food or a bioidentical hormone is called a medicine. And what medicines rely upon, they're not bioidentical, they're not similar to a molecule in your body. They're reliant upon your body's reaction to that.
Right.
Well, there is a place in this world for medicines. Absolutely there is. And there isn't a medicine you can't name me, from homeopathy to chemotherapy, that in some person at some time doesn't have tremendous merit. But this is not a reaction. Your ovaries are not going to react. So I would not approach something as significant as menopause where the stakes are so high. You could try homeopathic medicines, but get that 24-hour urine hormone test to make sure that you're getting in the proper zone, because your life is going to depend how active you are, whether you're staying at home when you're in your 80s or you're going into an assisted living facility. These stakes are tremendously high getting these right, where you're going to lose bone or you're not going to lose bone. Yeah, that's what that doctor said. In the Little House on the Prairie days, they didn't have many years to lose their bone. Now you've got a decade or 2 or 3 to continue to lose your bone.
Right.
So if you're going to experiment with something other than replenishing what you're missing, try it. I would not recommend it. I don't recommend it. I don't recommend herbs for this purpose. These are medicines. They have their specific place. They're wonderful. They're capable of doing so many things, and homeopathic medicines are capable of doing so many things. However, if you're going to be messing with trying to replenish your hormones with anything other than the hormones, just make sure you get the 24-hour urine hormone test to make sure it's working and you're getting adequate hormone levels.
Right. And, oftentimes women will write, well, how do I get the 24-hour urine, and where do I get it? Do I get it online? And how do I read it?
Well, this is the excellent question, and this is the deal. I'd say the major job for women actually turns out to be that you go shopping until you found a healthcare professional that you really like and you really trust and is really an expert. That's what you need. Unfortunately, women have had to take on the whole subject of menopause themselves, because when they go out there to meet so many of who's treating a menopause, they're not getting the excellence that is so crucial that they get.
Yeah.
I mean, I told this example on on our time together before, where I had an interest in automobiles, and I even I like to tune my own carburetors. I had a 1962 Volvo. Oh God, it was so fantastic! It was my favorite car of all time, and I took a stethoscope to tune the two carburetors. And then I got more adventurous, and I started doing more of mechanics, and then I rebuilt a Corvair van engine. I rebuilt the engine, and by God, it was so much fun. I had the whole thing apart and put it back together and followed the manual, and it was the very first engine I ever rebuilt. And that car worked. When I turned on that engine, it worked, and it worked for a full 7,000 miles, and that was it. It froze. It became a playground. So I had a Volkswagen van after that, and it needed an engine rebuild. And I took it to a mechanic. I was so interested that the mechanic let me hang out with him while he rebuilt the engine. And I saw, oh my God, he's doing 50 things every step along the way that I never even thought of.
Did you bring your stethoscope?
Didn't need it for that. And I said, this is why my engine froze after 7,000 miles, because this mechanic has rebuilt a ton of engines and he knows what to do.
Right.
And you're playing with hormones.
They're strong.
Your job turns out to be, yes, read our book. Yes, read Estrogen Matters. You can be part of the process. In fact, in our method, it's very important that you're part of the process. But your job is go shopping until you find someone you trust who's a healthcare professional who can write those prescriptions and knows what they're doing. And we have a membership in the Menopause Method. That's one way to do this. But that's your job.
Yes, it is. It is. And you read, go ahead.
Go ahead.
No, go ahead. You had brought up in our last interview, which is just to me so important, so fascinating, that an entire FaceTime needs to be devoted to it. But you say that the women who have symptoms are the lucky ones. They're the ones who are lucky because they are the ones who are going to go out, and I am living proof of that for sure. I was not going to give up. They're the ones who are going to go out. They're going to look for relief. It's the ones that do not have symptoms, as we talked about earlier, who might not fare so well, sadly. Right?
Yeah. Exactly. Precisely. There's 25% of American women do not get symptoms. And they're looking around and they're wondering, why is there all this hullabaloo about menopause? And they're the ones I'm most concerned about. And I'm just repeating what you said, Carolyn. There's 75% of women who do get symptoms, and they're often life-stopping, and they're often very disturbing, and they're a big problem. But what I know about these women is they're in the best position of all, because they are motivated, just like you were. They're going to get this job done, a lot of them. And those symptoms are going to drive them to get this job. So you want to be thankful. It's a funny way to put it, but you do. From my perspective, you are the lucky ones. And what I'd really like to say is, all women, when your period stops or long before it, go shopping. Find that healthcare professional. It's going to serve you for your whole rest of your life.
Absolutely. Absolutely. I mean, I know for me, woo, I went 17 years without hormones, and I made sort of a joke about taking away someone's insulin. I felt like all my insulin had been taken away. I mean, it was just awful. And I did that doctor shopping, and I got very lucky because who did I find? You. So I got lucky.
I had a request from someone that I'd like to honor, and they wanted me to point out our book and to go in and zero in on some subjects that are in our book. This is a book about menopause and bioidentical hormones. That's what this is. Happy, healthy hormones. But there's other things in it as well. And here's a chapter 18, in praise and honor of the bladder. Squeeze. That's the title of that chapter. Because your bladder is going to really matter for you, that for every day that you're on earth, that it is functioning decently. And we talked about this a little bit in the beginning, and I highly recommend that you go do that chapter, because there's a couple functions of the bladder that if it stops functioning, you start losing your urine when you cough or just spontaneously, and you have to get into adult diapers. You don't want that. And there's a couple things to do. Number one, get those hormones right. It's hard to have a healthy bladder when you have vaginal atrophy, because the bladder empties into the vagina, and when the vagina gets thin and dry, it irritates the opening to that bladder called the urethral hiatus, and you can get chronic, recurrent bladder infections and cough incontinence just from the vaginal atrophy. But there's that other piece that I was mentioning earlier. It's the holding up of the bladder by the levator ani, a big muscle. And so you don't want to get sarcopenia, that muscle that it loses its strength and it doesn't hold up anymore. That's a big deal. So why do we say squeeze is part of the title of this chapter? Because that muscle could use exercising just like any other muscle in your body. And there was a Dr. Kegel who suggested how to do this. So
that's right.
It's very common to think of Kegel exercises, but what they are, and let's all do it together here.
One big squeeze.
Squeeze our anus.
Have a group squeeze.
Group squeeze. Squeeze that anus. Relax it. Squeeze it. Relax it. Squeeze it. Relax it. That muscle is the muscle. That's the levator ani. And I have one patient who said she put a sign above her toilet paper roll so that every time she went to the bathroom, it says squeeze. And there's other suggestions I've heard is every time you come to a stoplight, if you're a big driver, squeeze. Remember to squeeze, men and women, but women in particular, squeeze, because you're going to love preserving your bladder so that it doesn't give any trouble for every day that you're on earth.
Elizabeth says, now this is an exercise I can get behind. So we're going to do it 7 a.m.
The very best exercise possible is orgasm.
That too.
So talk about exercise the levator ani. Use your imagination and figure out how to do that one.
Yeah. That's yet another interview.
No matter how you do it.
Elizabeth says,
that whole pelvic area is going to contract in a most healthy and health-preserving way.
That's so funny because Sarah says, great when doing dishes. I don't know if she's talking about the orgasm or the squeezing. So, yeah, I mean, oh, God, I get so sad when it starts to come time to close because there's so much vital information in here. The levator ani, women talk about prolapse. Scary.
And what prolapse mean is that the bladder and the uterus reside in the pelvis, and they're held up in that pelvis by
Right.
ligaments and the levator ani muscle.
That's
And it's
right.
that levator ani muscle which is prone to difficulty because women often stretch that muscle very in a huge way in childbirth. So
Absolutely.
women have a vulnerability there. So, associated with childbirth, when I used to deliver babies, we used to instruct the women in the postpartum period, start doing those exercises where you're squeezing your anus, because we want to rebuild the strength of that levator ani, because you're going to want it in the long haul. And yeah.
Yeah, I mean, because it really isn't a whole lot. There are, but I mean, incontinence is not one of the more pleasant things either to have or to deal with somebody who does have. It's sad, and if it can be prevented in any which way, shape, or form, let's go for it. Elizabeth says if you have Ehlers-Danlos, connective tissue disorder, she had said that her mother had a bladder tuck surgery. So I guess that there are ways to fix this as well. Is that correct?
I read about and was taught about Ehlers-Danlos in medical school, and that was the last time I heard about that. And since that was 52 years ago, I'm very sorry. I won't be able to help you with that one.
Yeah, it comes up though. Ehlers-Danlos comes up a lot. Comes up a lot. And then she goes on to say if she had had hormones. So it just brings us right back to where we started, which is that hormones are important. Hormones are vital. They're important. They are imperative, I believe, to replace. Living without them feels horrific. And my heart goes out, to anybody who is having a really hard time in replacing these hormones that we've lost.
There's a question I see up here that I would like to say out loud and answer.
Please.
It's from a woman named Leon Marie.
Mm-hmm.
Doctor, what do you say to women who claim that diet and exercise will prevent the diseases linked to ovarian hormone loss? I'd say I don't agree. Now, who in the world would ever challenge or dispute the importance of diet and exercise? My God, I've been so rigorous in this department myself because of all of us know that we want to eat really wonderfully. And we also want to exercise wonderfully. And it is not going to do it. And there's been so many women who've tried this experiment. And once you try the experiment of just not trying to replenish the hormones, there's going to be a certain high percentage of women who are going to have the deleterious effects. And then what? It's harder when you've lost a lot of muscle to regain muscle. It's harder, but it's still doable. But I'm going to assert that these hormones are so powerful, and you're not going to be able to produce the hormones by eating properly and exercising properly.
True.
You won't be able to do it. And you won't even be able to get the optimal amount of value out of exercise if you're not supplementing hormones.
Well, you kind of can't exercise.
I've told this story on this Facebook Live several times, that I had a friend who is in her 60s. And when she was getting symptoms of menopause 20 years ago, out comes the Women's Health Initiative scaring her and millions of women about taking hormones. It was incorrect, as I've said many times. Now, this woman was an athlete all of her life, is an athlete, and she's very careful with her health, including her diet. And she said, I'm not putting myself at risk, and I'll do it with diet and exercise. And what happened? 20 years later, significant muscle loss. So to watch her climb a stairs, she's got to hold on to that railing. And she's an avid exerciser, walking every single day, vigorously, doing all kinds of stretching and exercise. But you need these hormones for muscles, for bones, for cognition. So I'm going to give you my best shot. I say these hormone replenishment in women and men, you talk to a man who's lost his erection because he doesn't have enough testosterone and tell him, well, it's natural. It's not that big of a deal. Or you
Right.
can get it done with diet and exercise.
Ooh.
No.
Yeah,
So
no.
everyone should approach life like they want to. But I want to give you my best shot is take on these hormones. You're going to be so grateful if you do and get it right. And if it takes you a while to get it right and to find the right, if you have to go doctor shopping, just get this job done as excellently as you've ever done anything in your life. And 30 years from now, you'll be thinking of yourself, oh my God, look what I chose to do. And look at the difference between me and the other 9-year-olds here. Ever seen a 90-year-old on a ski slope? They exist.
They do.
And so anyway,
Even ballerina.
That's what I have to say about hormones and diet and exercise. Do them all. Don't leave any one of those out of there. Don't leave impeccable diet and don't leave exercise out of your regimen, and don't leave hormones out either.
Right. Which,
do them all.
yes, again, can sort of become like the elephant in the room, and sadly, but I think that we're making headway. I really do. I think we're making good headway, and I think that hormones are getting their due diligence. Finally, there's still a ways to go.
So let's do one more question today, Carolyn, and then I'm going to.
Yeah, and then I'll have Andre help me with this because this is annoying to me that I can't get to these questions. Rod says, how does IF and OMAD, which I have no idea what that means, affect women's hormones in menopause? Do you know what IF means and OMAD means, Doctor?
I'm thinking. I'm trying to find that question myself. Is it near the bottom? Yeah, I see it.
It's at the top.
I'm so sorry. I need much more definition, and my guess is IF is fertilization.
Yeah, I thought IF was that too. Oh, intermittent
fasting. I don't know that it does. There's so many people on this earth that are going to benefit from intermittent fasting. One meal a day, I see.
Yeah.
And one meal a day. And here you're opening up the world of nutrition. And my favorite book on nutrition was written by a PhD who said, "Are you confused?" Because Dr. Irola was talking about that there's so many millions of approaches to nutrition, you can go ballistic. Let me give you what I think is so crucial and what you all probably know. And that there are things that are universal in nutrition. Universal. Everyone. That means everyone. And the first one is organic. And the second principle is organic. And the third principle is organic. Garden. Get the best organic you can get. And then here's another one. Chew your food.
Yep.
Digestion, it doesn't matter so much what you put in your mouth. It matters what you can digest. And the older you get, the harder it is to digest. You don't have the same equipment. Chew that food. And don't get hypoglycemic. And there's a few other universal principles. But now we're going into questions about different approaches to things. Notice I'm not saying vegan is the way to go.
Right.
And I'm not saying carnivore is the way to go. Or combination is the way to go. This is for every individual to figure out, and genetics can help. And you can just ask, what did my ancestors do? And you can pretty much make a guess that that's how you're designed to do. And like, you don't want to take someone whose heritage is totally from the equator. and they've been genetically evolving in the equator where they didn't rely heavily on animal food. In fact, it's rather rare. So genetically, they evolved to do really well with vegetables and fruits. These people usually are going to find their way to a vegetable and fruit-based diet, and they're going to make it a religion. And otherwise, the flip side of that is if you take someone from the way northern hemispheres, the Arctic, and just shy of the Arctic, these people had to rely heavily on animals.
Mm-hmm.
And genetically, the ones who survived were the ones who could eat, and what they had to eat was the animals. And genetically, they're set up to do it. And so you don't. And as one absolute expert on cancer and nutrition said, you don't want to take someone who's genetically designed to deal primarily with vegetables and turn them into a carnivore. You're going to kill them. And likewise, you don't want to take someone who's genetically designed to live off of high protein diets and they need animals. You don't want to turn them into a vegetarian. You're going to kill them. But I don't want to make it too complex. Just find your way. You'll find it. And I'm not going to elaborate on that. Now I want to get into some of these other things that can really make a difference. And this is what the questioner is saying: 1 meal a day or intermittent fasting. Boy, there are some people, and I'm one of them. I won't eat until noon, and I will have my window of eating between noon and hopefully 7 if I can possibly pull it off. And this is the whole subject of, this has become very popular, basically ketosis diets or intermittent fasting. There's a lot of excellent rationale for this. And that's one of the reasons I do it. And it takes us deep into metabolism when we think of doing this. But the bottom line is explore it. As you find, this is something for us to try, to fast intermittently. It's a known longevity technique. And do intermittent fasting where you're only eating a certain number of hours during a day. I like it so much, that's what I do. I noticed that I wasn't someone who liked breakfasts very much. And then I grew up in an era where they said, eat your breakfast, eat your breakfast. So when someone taught me about intermittent fasting, I went, man, this is my home territory. I'm glad someone taught me about the benefits of this. Yeah. So I'm not doing a very good job of this, but it's a subject worth taking on, especially in these days where we have insulin and glucose regulating issues and insulin resistance. So I'm just bouncing around on the surface of a subject that's worth investigating, and it's called IF and OMAD. I just learned that this day. Intermittent fasting and 1 meal a day. There's merit to it, but don't take on any rules. You need to find this for yourself. There's people who have adrenal issues and hypoglycemic issues that if they subject themselves to 1 meal a day, how are they going to survive?
Yeah.
Well, here's the thing. Have you ever noticed that sometimes you're hungry, but you didn't eat? And then the hunger disappears? Mm-hmm. How in the world did that happen? Well, your body is going to protect you from hypoglycemia when your blood glucose drops. That's where the hunger came from. How does the hunger go away? Well, you recruited some powerful hormones that did some major biochemical stuff to bring up your blood glucose again. Right. Yes, you keep challenging your adrenal glands, and a lot of people have challenged our adrenal glands like for a long period of time. It's a very harsh thing to do. So there are no rules outside of organic and chew your food.
Right. Well, because it's really important. I mean,
you've got to find your way. So I would never recommend 1 meal a day to someone who had adrenal fatigue, and you don't want to force your adrenals into having to recover your blood glucose. So big topic. We just walked into a big ocean. Because of other commitments that I have today, I'm going to call it a day. And I'm going to be
call it a week
on the weekend, so I won't be here on Thursday. Special friend coming in. So I'll see you next Tuesday.
I want to thank everybody for being here. Let me close out with this. If people have asked, they need more information about how to get with you, how to get with Menopause Method, doctors that might be in their state, I can go ahead easily and take care of that. Just write to me. I'll help you with that. And thank you, Dr. Rosensweet. Always, it is such a pleasure to have you in our back room on Tuesdays and Thursdays. And you saw that picture, right? That was a fun picture, wasn't it? The one that I sent from our last interview of laughter.
Oh, I haven't seen it. But I want to run right now, Carolyn. And so until next week, everybody, good to be with you.
Okay, you guys, everybody have a great weekend and be safe, or great week and weekend, and be safe and be happy. We'll talk to you Tuesday. See you there. Bye-bye.